Thank you, everyone, and good morning, good afternoon, and good evening to everyone. My name is Kathy Trieu. I'm a research fellow in the Food Policy Division at the George Institute for Global Health, and I'm a conjoint senior lecturer at University of New South Wales. Firstly, thank you to Dr. Renuka for the opportunity to present today, and thanks to everyone that is joining the call. I'll be sharing an overview of national salt reduction efforts from around the world and their progress over time, and then briefly highlight some parallels between salt reduction and iodization programs so that we can achieve both public health goals. So just some background to start. There's clear evidence that there is a direct relationship between sodium consumption and blood pressure. Eating too much salt or sodium causes raised blood pressure and thereby increases one's risk of cardiovascular disease as well as chronic kidney disease. And there's growing evidence now that suggests that high salt intake is also associated with stomach cancer. So in 2013, it was estimated that almost all adult populations worldwide exceeded the recommended daily intake of sodium. As you can see on the graph, the global average sodium intake at the bottom in black is around double the WHO's recommended levels. And so global salt intake is around 10 grams of salt per day or 4 grams of sodium per day. And this is roughly the same in the South Asia region, as you can see in the light blue point here. While this study is a little outdated now, there's little evidence to suggest that sodium intake has improved in many countries. So these regional estimates are likely to be the same. More recently, the Global Burden of Disease study estimated that high sodium intake was responsible for almost 2 million non-communicable disease deaths in 2019. And it's the leading dietary risk for death worldwide, as you can see in the graph. The high burden of disease that's associated with excess sodium intake has been well known for some time now. And that's why in 2013, the World Health Organization established a global target to reduce sodium intake by 30% by 2025. And this is part of 9 global targets to ultimately reduce premature mortality from non-communicable diseases by 25% by 2025. And this was also endorsed by all member countries. So since the establishment of the global salt target in 2013, we've been monitoring countries' progress towards the targets in terms of salt reduction initiatives implemented, as well as reductions in population salt intake. We've actually been monitoring this since 2010, but we've taken a more comprehensive approach since 2014. So in 2014, as you can see in the image, a year after the global salt target was set, we identified 75 countries with national level salt reduction strategies. And this is shown in blue or green on the map. The number of initiatives have more than doubled since 2010, when there were 32 national salt reduction strategies identified. Countries in red had no strategy developed, and countries in yellow were planning a salt reduction strategy at the time in 2014. Today, I'll be presenting more details about the salt reduction efforts in 2019. This was an important year as it represented the midpoint between the year the global salt target was set and the year that it should be achieved, 2025. So we wanted to understand how countries were progressing. So just very briefly with the methods, we searched peer-reviewed literature as well as grey literature. We also consulted international experts around the world to see if we missed any countries with national salt reduction strategies. We then generated a database of all the initiatives, and we used that data collected to pre-fill questionnaires that were then sent out to country program leaders around the world. And we asked them to verify the information we had collected, as well as supplement or update the data we had collected. We included salt reduction strategies if they were at a national level and they had some sort of government involvement, and if there was a written strategy or one or more initiatives that were specific to salt reduction. So countries that just had education on salt reduction as part of a broader nutrition education initiative were not included. Then we collected information about who led the program, what type of initiatives are being implemented, were they voluntary or were they mandatory initiatives, and also what's being monitored, and also whether they're having an impact on population salt reduction or not. So what did we find? So in 2019, there were 96 countries with national salt reduction initiatives around the world. That's almost a 30% increase from 75 national strategies in 2014. Notably, we saw a substantial increase in legislative approaches from 33 countries in 2014 to 60 countries in 2019. We also saw a doubling in countries implementing more than one legislative approach. So where's the progress occurring? As you can see in this graph, the greatest increases in national strategies by WHO region are occurring in Europe, the Americas, and Eastern Mediterranean region. In contrast, there has been no change in the Southeast Asia region or in the Africa region. And in the Western Pacific region, there's a slight reduction in salt reduction strategies. It should also be noted that we used WHO regions here, and there are 11 member states in the Southeast Asia region. And of those, 5 have a national salt reduction initiative. So that's in Bangladesh, Bhutan, Indonesia, Sri Lanka, and Thailand. And 2 countries have planned initiatives. Based on the 2019 World Bank income classification, the biggest increases in the number of countries with initiatives are in the high income and the upper middle income countries. So what type of initiatives are being implemented to lower population salt intake? Well, the most common initiative are interventions in settings, which is being implemented in 74 countries in 2019, and this substantially increased since 2014. These mostly include voluntary nutrition guidelines or mandatory restrictions on foods procured in public institutions, and this includes schools, hospitals, government offices, as well as workplaces. And I've included some examples of these initiatives on the bottom right. So these initiatives can take the form of guidelines or restrictions, and they can be nutrient-based, for example. So here, in the US, snacks served in all city agencies may not contain more than 230 milligrams of sodium per serving. So that's an example of a nutrient-based criteria. There can also be food-based criteria. So for example, in Malaysia, school canteens may not sell pickled items due to their high salt content. Then there's other forms of criteria, for example, salt containers or salty condiments should not be readily available in school dining areas. So the second most common initiative is to encourage food reformulation, with 68 countries at least engaging or having meetings with food manufacturers about sodium reformulation. Of those, 57 countries have taken the next step to set a voluntary or mandatory sodium content target for packaged foods. And of those, 19 have mandatory sodium content targets or limits for packaged foods. On the bottom right, I've included an example of some sodium content targets that the World Health Organization established last year. The WHO global sodium benchmarks were developed through collating existing sodium content targets from around the world, and the lowest or the strictest sodium target was chosen as the global benchmark, as you can see in the last column. So, for example, raw meat products and preparations such as fresh sausages must not have more than 250 milligrams of sodium per 100 grams. And this target was borrowed from the United States. The third most common intervention is any sort of consumer education initiative, whether that's awareness raising campaigns, mass media campaigns, or behavior change communication strategies. In 2014, consumer education initiatives were the most common. However, in 2019, the number of these initiatives have reduced to 50. We think there are several reasons for this reduction, including the high cost of sustaining consumer education initiatives, and also once high levels of knowledge and awareness about the adverse effects of excess sodium is achieved, then countries tend to focus on other structural or environmental interventions. One of the most well-recognized salt reduction campaigns is Sid the Slug from the UK, and that's pictured below. So the last two salt reduction initiatives include front-of-pack labeling and tax on salty foods. So over the last 5 years, there's been increasing adoption of voluntary or mandatory front-of-pack nutrition labeling schemes. And now it's being used in 48 countries. Of those, 12 countries have made it mandatory to use the front-of-pack labeling scheme. These front-of-pack labeling schemes are supposed to be an easy-to-interpret label that's displayed on packaged foods. And I've included some examples on the bottom right corner again. So for example, there's the voluntary health star rating system that's being used in Australia, the traffic light labeling system that's from the UK, Nutri-Score, which is being used in France, Spain, and Belgium. There are also symbols and logos, such as the Nordic keyhole, which is being used in Sweden, Denmark, and Norway. The Healthier Choice logo, which is used in Singapore, as well as mandatory warning labels about high sodium. And this example here is from Chile, where products have to display a black stop sign on the packet of these sausages here due to its high sodium content. And lastly, 5 countries have a tax on high salt products. For example, Hungary have a public health product tax on salty snacks, as well as condiments that exceed a certain salt limit. And Fiji has a tax on MSG or monosodium glutamate. So overall, there's been an increase in monitoring of salt intake, salt levels in foods, as well as salt-related knowledge, attitudes, and behavior since 2014. In 2019, 25 of 96 countries measured changes in population salt intake. Of those, 17 countries reported a reduction in salt intake of more than 0.5 grams of salt per day. And these countries are shown on this slide. Only 3 countries have achieved a reduction in salt intake of more than 2 grams per day. 9 countries have achieved a moderate reduction of between 1 to 2 grams of salt per day. And lastly, 5 countries have reported a slight decrease of between 0.5 to 1 gram of salt per day. 7 countries reported minimal to no change in salt intake, and 1 country had a slight increase in salt intake. It should be noted that the methods used to evaluate these changes in salt intake varied between countries, with the most using 24-hour urine samples, followed by dietary assessment methods, and then spot urine samples. So this slide shows that reduction in salt intake has been slow and quite gradual across countries. There are now 31 countries monitoring changes in salt levels in foods. 9 countries use laboratory or chemical analyses. 6 countries use food label surveys, and you can see a photo from our colleagues collecting salt information in Vanuatu. 3 countries rely on industry self-reported data, and 1 country uses sales-weighted data, and 6 countries apply a combination of approaches, most of which involves food label surveys plus another method. And lastly, 19 countries are monitoring changes in consumer salt-related knowledge, attitudes, and behavior, which is up from 7 in 2014. So I'll now just briefly outline potential programs or areas of integration between salt reduction and salt iodization programs, as both public health goals are necessary and compatible. And we heard some of these from Dr. Arnold Timmer already. But I hope that through my presentation, you'll be able to identify other ways to integrate the 2 strategies in your country. So the first parallel that can be leveraged is the methods in monitoring and surveillance. Both strategies use urine collection as well as dietary surveys to monitor intake levels. So for example, when we were measuring population salt intake levels through 24-hour urine collection in Fiji and Samoa, for women aged 18 to 45 years, with their consent, instead of taking 1 sample from the total 24-hour urine collection for the laboratory, we just took 2 samples, 1 for the measurement of sodium and then 1 for the measurement of iodine. Dietary assessment methods are commonly used such as 24-hour diet recalls, are commonly used to understand the sources of salt or sodium in a population's diet. And this can be similarly used to inform the sources of sodium, sources of iodine in a population. By monitoring salt and iodine in the same surveys, they are not only huge savings in cost and time, but it also reduces the burden on the population being surveyed. The second potential area for integration is in communication and education, so that the two health messages are complementary and instead of contradicting each other. So we can use messages such as the example from Italy, which is little salt but all iodized, or use iodized salt but less of it, and eat less salt and only iodized. The third overlapping area is that both programs require engagement with food industry, particularly in countries where packaged foods are commonly consumed. So for example, interventions engaging and encouraging food manufacturers to reformulate salt levels in packaged foods can also ensure that manufacturers are using iodized salt. And lastly, there is potential parallels in the research of the 2 topics. So for example, when monitoring change in salt intake, if feasible, programs should also monitor change in iodine intake. And even in the review of salt reduction initiatives around the world, the study I just presented, we included a question in the survey that was sent to country program leaders around the world, and we asked whether there have been any programs, policies, or initiatives designed to eliminate iodine deficiency in their country, and whether this was done in coordination with salt reduction strategies. So I'd like to finish by acknowledging my co-authors on the review that I just presented on. I'd also like to thank those on the call who are working hard on either reducing salt intake or eliminating iodine deficiency disorders in their countries. Both are complex public health priorities, and hopefully through improved coordination and collaboration, both public health goals can be achieved. So